What's their cognitive status like? What's their general immune function? And again, is this something that's acute or chronic? What are their reserves potentially like? And do they currently have an underlying respiratory or GI disease? Just after I'd become aware of the BOLUS framework, and I've been using it with a few patients in the community and had been getting really positive responses, a young gentleman with a history of TBI came into our care. So this young man was around about 18 years old at the time. He was 20 months, around almost 2 years post TBI. And he'd been nil by mouth with peg feeding for that time. So there were some intermittent trials with speech pathology, but he was essentially nil by mouth for almost 2 years.
Welcome to the Dysphagia Research Bites podcast, which is a podcast designed to make dysphagia research more clinically digestible for speeches, especially those working in home and community-based settings. My name's Chantelle, I'm a speech pathologist, and I started this podcast because dysphagia care doesn't just happen in hospitals. It happens around kitchen tables, in aged care facilities, and in everyday life. Community dysphagia work is complex, it's nuanced, and it's often underrepresented in conversations about swallowing. So, if you're looking for clinical tips and thoughtful, evidence-informed conversations that actually translate to practice, you're in the right place. After a decade across acute care, ICU, and neurological rehabilitation, Melissa Kane founded Medical Speech Pathology in 2022 to bridge the gap between hospital and community care, bringing mobile fees, objective measurement, and evidence-based rehab into the private community setting. Her clinical interests span dysphagia, voice and upper airway disorders, orofacial myology, functional neurological disorder, and the role of the autonomic nervous system in communication and swallowing. She is one of a small number of speech pathologists internationally with a dedicated clinical focus on Ehlers-Danlos syndrome and is actively involved in international research aimed at improving awareness and access to informed care for the EDS community. Alongside her clinical work, Melissa contributes to university teaching and professional education. Welcome, Melissa.
Thank you so much. I'm really excited to sit down and have a proper chat with you. Been a big fan of your work for a while now. So obviously when you reached out and asked about a paper that has changed my practice, the BOLUS framework immediately came to mind. So very happy to be talking about that today.
Excellent. The paper that's going to guide the discussion today, so the one you've chosen, is called Risk of an Adverse Event in Individuals Who Aspirate, a review of current literature on host defenses and individual differences. So this was published in the American Journal of Speech Language Pathology by Palmer and Padilla in 2022. So this paper discusses an important topic in dysphagia management, which is what contributes to whether or not aspiration leads to serious health consequences. So as speech pathologists, we know that when someone has oropharyngeal dysphagia, there's a higher chance of aspiration happening during eating or drinking. And aspiration in turn can increase the risk of complications like aspiration pneumonia. But, and this is a key point, these outcomes aren't caused by aspiration alone. So there are many other factors at play. So ultimately, the paper offers a framework to help clinicians think beyond, is aspiration happening? And instead asks, what risks does this person have? Which ones can we modify? And when is a certain level of risk acceptable? So they created what's known as the BOLUS Framework. And we're going to start by going over what this framework is. Mm-hmm. Melissa, can you talk us through what is the BOLUS Framework?
So the BOLUS framework takes existing research that's not any new evidence, but it takes it and puts it into a really practical framework that allows you to almost problem solve through different variables and identify risk factors for a given patient. So under B, we're thinking about the bolus that the person is aspirating and their response to that aspiration. So are they aspirating thick fluids, thin fluids? What is the frequency and the amount of aspiration? So obviously there's a big difference if someone has trace aspiration every fifth mouthful versus gross aspiration of every consistency.
Mm-hmm.
The level of the aspiration, so how far down is it reaching essentially, and whether that there is any cough response to that aspiration. So again, a different scenario if someone is consistently silently aspirating or whether there is some attempt to clear the bolus.
Absolutely. And I think one thing that I think we might do fairly well is just in regards to maybe the level of aspiration. So I think it's quite routine for us to be using the penetration aspiration scale when we're doing video fluoroscopies and reporting on that. How do you think we go with those other areas? Do you think we look at those other things just as closely as we do with sort of the depth of aspiration?
I think we're starting to,
Yep.
but I don't think that we currently, as a profession, give it as much weight as the aspiration itself.
Mm-hmm.
Particularly given I know that I feel that the tide is shifting with all of the research that's coming out around, I guess, the negative consequences of aspirating a thickened fluid versus
Yes.
how about aspirating, say water. So there is, I think, we're gaining momentum, but I still don't see that reflected, for example, in a video fluoroscopy report
Yep.
around consideration of those factors.
Yeah. Yep. Great. Thanks, Melissa.
Then moving on to oral cares. As speech pathologists, we're very well aware of the importance of oral care, and this looks at the patient's oral health. And it is important to screen for conditions, perhaps like dental conditions and things like gingivitis. We can use the oral health assessment screening tool just as a really nice brief snapshot of their oral health. We want to be looking at their saliva management. And again, a nice tool is the drooling frequency and severity scale. And then looking at the patient's oral care routine and whether there are any opportunities to improve that, make it more consistent. So then moving on to L, lifestyles and ADLs. So again, we know from research such as Langmore's Predictors of Aspiration Pneumonia paper that dependence for oral care and oral intake are big risk factors, for developing an aspiration pneumonia. So really looking at what the person is able to do and what support they need is very, very important. Looking at their mobility and activity levels, whether that is also, for example, if there have been changes in those areas, whether they're acute or whether they're more chronic. So obviously a very young, healthy person who has undergone changes will have a different sort of resilience perhaps than someone who is frail and deconditioned and elderly. And also important, obviously, thinking about pulmonary clearance and things like that. And then looking at whether they smoke, whether they drink alcohol, those type of factors can increase their vulnerability. So then moving to U, which stands for unintended or iatrogenic risk, so essentially the consequences of medical intervention. The first one is the presence of tubes, so things like tracheostomy tubes, feeding tubes, and these can increase the risk of bacteria migrating into the lungs. Something like a PEG tube even can increase the risk of refluxed contents ending up in the lungs and ending up in something like an aspiration pneumonitis. We've got mechanical ventilation,
Mm-hmm.
medication side effects, and things such as increasing, decreasing a person's saliva, impacting their attention, impacting their cognition or their general immune system. And then finally, we come to system health. So we're looking at the overall person's general health. So we're looking at are they frail or not? What's their cognitive status like? What's their general immune function? And again, is this something that's acute or chronic? What are their reserves potentially like? And do they currently have an underlying respiratory or GI disease?
Okay, so Melissa, why did you choose this particular article?
I first came across the BOLUS Framework. I was listening to a couple of podcasts, the Swallow Pride and Swallow the Gap podcasts, and the authors were being interviewed. And immediately it just felt like a crystallization of so much of the research that I had been reading and how my own, clinical practice was changing. And I just felt like it was just such a tangible tool. And so I immediately went and did a deep dive and found out everything I could about the framework, accessed a few webinars and things from the authors, even ended up reaching out to the authors and collaborating with them. But yeah, just really appreciated the clinical sort of applicability of the framework.
Um, do you think we have anything similar available for us to use,
Um,
similar to the BOLUS framework?
Sort of, like because it is
Mm-hmm.
based on existing research. And so, I guess some of the tools or research that I used heavily were things like, the predictors of aspiration and pneumonia and Dr. John Ashford's three pillars of aspiration,
Mm.
those types of tools. But to my knowledge, or at least I wasn't aware of something that was so comprehensive that really drew together all of the existing research across all these other, as you sort of mentioned, perhaps slightly non-speech pathology domains. So no, I think this is really something new and exciting that didn't exist before.
Yeah, yep. Now, on that point as well, so you mentioned John Ashford's work and the three pillars, and that's something that, prior to Bolus, I used to reference a lot because I think that's a really sort of nice way to frame things, and it sort of simplifies it, I suppose, if you're communicating to your clients about risk. But it is a bit more complicated than just sort of three things. And, the pillars aren't three things, but they're sort of three sort of categories.
Mm.
But in a way, I want to get your thoughts on, do you feel like it's maybe complicated things a little bit more because we have so many things that we're supposed to look at now? What are your thoughts on that?
Again, yes and no,
Mm,
because I think yes, obviously there's many more things to consider, and perhaps some of them that we weren't necessarily considering, and perhaps aspects that take a bit more collaboration with a multidisciplinary team to find the answers to.
hmm.
But essentially, I think those factors were still factors,
Yeah.
and there were still variables that were contributing to our, the overall risk profile. And so I think that the topic of, of risk assessment is by very nature complex. And
Hmm.
so by almost making that complexity a little bit more transparent, I think it is incredibly useful. So yes, it's going from maybe having a smaller list of variables that we're discussing
Hmm.
to a whole lot more, but I think that's incredibly valuable given the subject matter.
Yep. Okay, so let's talk about the clinical application of the bolus framework and how this might look in practice. So, Melissa, you said you've got a case study, and is this something that's being published as well, did you say?
Yeah, so essentially, after I used this framework with this particular patient, it was such a transformative experience that I reached out to the authors and um, to see whether they would be interested in collaborating in writing this up as a case study, which I was very happy to see
Great.
that they were. And that's just been an amazing experience working with them. So, yes, we are in the process of publishing that case study.
That's amazing. Congratulations.
Thank you. Yeah, just a shout out to listeners as well to never be afraid to reach out to the authors directly and talk to them about their work. Okay, so just after I'd become aware of the BOLUS framework and I've been using it with a few patients in the community and had been getting really positive responses, a young gentleman with a history of TBI came into our care. So this young man was around about 18 years old at the time. He was 20 months, around almost 2 years post TBI. And he'd been nil by mouth with peg feeding for that time. So there were some intermittent trials with speech pathology, but he was essentially nil by mouth for
Hmm.
almost 2 years.
Mm.
And in that initial session with the patient and his family, it became apparent that they really had goals around returning to some form of oral intake. But they were using language like, we've been naughty, like we're not doing what we're supposed to do. And
Mm.
the young man was saying he was, quote unquote, sneaking water in the shower and things like this.
Okay.
And the language, this is one of the things that I absolutely love about the BOLUS framework is that, often there is, undue focus on the risks of aspiration,
Yeah.
and the possible consequences of aspiration, but not a whole lot of discussion around other potential risks, such as, reduced quality of life, or even, complications around the feeding tube itself, those types of things, or the fact that a feeding tube doesn't necessarily eliminate aspiration, if you're aspirating stomach, gastric contents.
Mm-hmm.
And so, actually, if I wasn't talking about this paper, the other paper that has changed my practice that I would have talked about is the Dr. Sean O'Keefe paper,
Oh, yes.
the risk feeding and aspiration. And he really nicely talks about these topics, and how the language that we use about risk is really, really important, because any decision, in healthcare carries potential risks, and benefits, and essentially consequences. And if we're not being a little bit more detailed about the possibility of those risks, not just saying, well, there's a risk that you may aspirate and, you may die, is very, very different from actually quantifying different risk factors and how they combine together. So in that initial session, I used the BOLUS framework to say, okay, so, your goal is to return to oral intake. Here are some factors, and let's walk through these different factors and just see, how your variables are sort of stacking up at the moment. Then let's have a look at any of those variables which we can modify. And also, it just provided such a nice framework, not only for that initial discussion, but to then communicate that with the wider healthcare team to really support that transition back to oral intake, that it wasn't just we're risk feeding and it's just about quality of life, because I
Mm-hmm.
do have a problem with that terminology as well, to use
Mm-hmm.
that at risk feeding,
Yep.
that doesn't quite convey the same message as a team. We have examined the different risk factor variables. Here is the patient's decision. Here is how we're going to proceed. And it just keeps the language a lot more neutral. It supports the patient autonomy,
Mm-hmm.
and sort of reduces that fear-based messaging around dysphagia care.
You've touched on so many things that I wanted to comment about, but I didn't want to interrupt you. But when you mentioned, some of the language that the client and the family was
Mm,
using, like you
mhm,
said, they feel like, or the client said he feels like he's been maybe a bit naughty, or they've been
mhm.
sneaking. I really think that's something that really resonates with me as a speech pathologist, particularly working not just in the community, actually. I think in any sort of setting, I feel that there is really a culture in our field that we're quite risk averse.
Yes.
And when we do talk about aspiration, it's without meaning to. I think we're communicating
Mhm.
this fear that.
I agree. And especially, it is a different context working in the community than working in acute care. There are
Mhm.
differences there, but the chance of someone, aspirating and dying immediately, that's not a common scenario.
Yep.
And yet I see a lot of people who that's the message that they've received, that if I
Yep.
have a sip of water, I'm going to die. And that's
Yep.
that's not, what the speech pathologist would have communicated, but that is the message perhaps that they've retained. So
Yep.
yeah, I think that we obviously need to check our own bias, but that's what I love about this framework, that it can present the factors, the variables in a much more balanced and probably neutral way.
Yep. And you also mentioned Dr. Sean O'Keefe's paper as well. A big fan of that paper too. I'm interviewing him tomorrow night as well on that
Oh
paper.
my gosh.
And yes, I really love that paper because it really made me reflect on how we're having these conversations, and how we really need to be focusing on presenting it, like you said, in a more neutral way, because I think as individuals, we choose to take lots of different kinds of risks every single day. And even if we're thinking about in the field of health and medicine, patients will often choose maybe not to have a certain medication or a certain type of treatment.
And I think that something that comes up time and again is even when we're doing all the right things, we're imaging and we're quantifying aspiration and we're trying strategies, we still don't know what the outcomes of that are going to be. Someone, as we know, there are people that aspirate a lot and don't get
Hmm.
aspiration pneumonia. And so I feel like it's just been drilled into us a little. I know it was in my training that
Me
almost
too.
like we need to avoid aspiration at all costs. And I've got to
Yes.
be honest, I still have that deep down somewhere inside me. It's really
Yep.
hard to fully let go of that. But just recognizing our own limitations of what we know about, yes, we've identified someone's aspirating, but do we know the risk then of of something happening? Not always. So I think just
Yep.
again, what you asked earlier about the complexity of these variables or of the
Mm.
framework. And I think this is actually quite a good thing to communicate to families and to healthcare teams. This is not a black and white aspiration equals pneumonia. And so I like
Yep.
the fact that it does really map out some of this complexity in this situation.
Yeah, so something else that I was thinking of, Melissa, is, we have this sort of hyper focus on aspiration and that's going to lead to aspiration pneumonia. The thing is, working with clients who are in the community, they're not acutely unwell. So
Mm-hmm.
most of our clients they're in good health because if they weren't in good health, then they would be in hospital. And
That's
so
right.
I don't think we consider that maybe as much as we should and looking at it from the lens of how well is this person able to tolerate aspiration. What do you think as a fellow community speechy?
I agree. And as I say, having worked in hospitals for many years, it is a different scenario when you're in that setting versus community. And that's the beautiful thing in community. The patients are generally stable. They've got goals around eating and drinking. They probably have at some point tried to eat and drink. And so you've
Mm-hmm.
often got those nice data points as well. And also using something like the BOLUS framework, we can reframe aspiration not as the worst thing that can happen, but just
Mm,
new information. So we don't have to treat, or I think sometimes as speech pathologists, we feel like we have to prevent it at all costs. Okay.
yeah.
And that if the patient aspirates, we have failed in some way. But by actually making the person, at the center of this decision making,
Mm-hmm.
and spelling out all of the things that can contribute to them getting a pneumonia, it really puts them in that position of power. And then if they do aspirate, then it's
Mm-hmm.
okay, maybe we change our plan slightly, but it's not like we have failed.
So your client you said had traumatic brain injury.
Yes.
Can you tell me about his cognitive profile?
Yeah, absolutely. So he has mild cognitive communication impairments, mainly in areas of attention, but otherwise sort of decision making and things like that. Like he has full capacity, and
Yep.
so he was very much able to engage in this discussion.
Yeah, great. And can you tell us a bit about the profile of your particular client in relation to the BOLUS framework? So what were some things that you sort of identified and how did you sort of weigh up risks and whatnot?
So, by the time he came into our care in the community, he'd had quite a number of instrumental assessments. So, we did have
Mm-hmm.
a fair bit of data on the bolus variables in terms of what he was aspirating. And he was essentially aspirating both thin and mildly thick.
Yep.
And so, given that research around, what is more harmful for the lungs, we
Mm-hmm.
actually ended up going with thin fluids because even if he was potentially aspirating slightly less of the mildly thick fluids, there were kind of equal or greater considerations for his health if he was aspirating thick fluids.
Yep.
It was also relatively, he was aspirating fairly consistently, but not large amounts, sort of trace to mild
Mm-hmm.
amounts. His oral health was okay. He did have an oral health plan in place, but we basically upped that, made it a lot more extensive, and also very consistent because he just transitioned into new community care. So we made sure
Yep.
that all staff were being very consistent with his oral cares. He is a wheelchair user and he was dependent for other people for both oral cares and for feeding. So that was an important consideration. But even though he is in a wheelchair, but he was engaging really regularly in physiotherapy, and so he was still quite active and mobile. In terms of the unintended or iatrogenic concerns, he did have a PEG tube, and he was actually experiencing quite a lot of vomiting. And while he didn't end up with an aspiration pneumonitis to our knowledge, it was certainly an elevated risk factor. And then in terms of his system health, he was generally healthy. There weren't any indicators of reduced immune function or reduced respiratory function. He did have a somewhat weak voluntary cough. Then we immediately implemented EMST, but his reflexive cough was relatively intact. So those are the variables that we considered, along with the fact that since his injury, he hadn't had a single aspiration pneumonia or really sort of respiratory event that we were concerned about, despite doing things like drinking water in the shower and things like that.
Yeah, yep. And something else I wanted to ask you about, just for the listeners, could you just clarify a term? You've mentioned aspiration pneumonitis. Can you just tell us about the difference between a pneumonitis versus an aspiration pneumonia, just for those who might not be familiar with that term?
Yeah, absolutely. So in an aspiration pneumonia, we're talking about generally like a prandial aspiration. So when someone's eating or drinking or swallowing their saliva, the swallowing mechanism is not working and therefore the contents end up in the lungs. Whereas when we're talking about an aspiration pneumonitis, we're talking about a chemical substance entering the lungs, usually gastric contents. And so this can happen when somebody vomits, and then the contents end up in the lungs. So it's just a different mechanism and generally type of material that's aspirated.
Thanks, Melissa. Now, was there anything else you wanted to talk about in relation to this particular client that we haven't covered already?
Well, I guess I'd just like to highlight how the application of this framework resulted in some really positive outcomes for this young man and his family. So, going back about a year ago now, when he first came into our care, so he was, as I said, nil by mouth, so with a functional oral intake score of 1. He's now on a voice score of level 5, so he is on a total oral diet. He's still having some of his food modified, so he's needing some special preparation for that. But he's actually due for a repeat video fluoroscopy next week, and we're actually hoping to make some further changes to his diet heading into the Christmas period, which is exciting.
And just on the voice, for those who may not know, so that's a scale. Is it from 1 to 7?
That's
You
right.
said, yeah, you said he
Yeah.
was 1, and that's nil by mouth, is that right?
Right. Yeah.
Yep. And so now he's on a 5, which is a total oral diet. What do you know what a 6 and a 7 would be?
Yeah, so level 6 would be he on a total oral diet with multiple consistencies without any sort of special preparation, but
Mm-hmm.
with some specific food limitations. And
Yep.
then level 7 is just normal, no restrictions.
Yep. Great. So to go from a 1 to 5, that's amazing.
Yeah,
Great.
functionally, it's obviously a big difference.
Yeah. Yep.
Some other measures that we looked at, so his eating assessment tool, the EAT-10,
Mm-hmm.
that's sort of looking at the quality of life and the impact of the swallowing problems. That's a score out of 40. The higher the
Yep.
score, sort of the more difficulty you have.
Yep.
So a year ago, he scored himself as 22 out of 40,
Mm-hmm.
with most of the score going for, it's caused him to lose weight, swallowing stressful, things
Yep.
like that. We repeated these measures about a week ago, and he dropped down to a 6 out of 40.
Wow.
So
Holy moly.
massive change. Yeah.
Huge change.
Yep. A few other measures that we took, I've already mentioned some of these. So the drooling severity and frequency scale.
Yeah.
A year ago, for drooling severity, he was scoring 5 out of 5, the highest level, which is profuse, drooling off the body and onto objects. So essentially, saliva was streaming out of his mouth.
Yeah.
And that's reduced down to a 2, which is a mild, so intermittent drooling and only the lips getting wet. Now that was a massive change in his saliva management.
Yeah.
Since we reintroduced oral intake.
Can I ask, how did you get it from a 5 to a 2?
Well, so we did engage in a lot in intensive dysphagia rehabilitation as well.
Mm-hmm.
And he has demonstrated some improvements to his swallowing. But his penetration aspiration scores have not changed. So he's still, he's still aspirating on the same consistencies to the same level.
Yeah.
But it makes sense, right? That he's gone from not eating anything, not really, the swallow was almost kind of put to the side, then to have, intensive sessions based on swallowing. It makes sense that he's not swallowing his saliva more frequently.
Yeah. Oh, amazing.
And then just the other part of that test was the frequency. So he's gone from a 4, which is constant drooling, down to occasionally drooling. What else did we do? I think those are probably the main ones.
Yeah, great. You were just on to your outcome measures, Melissa. All right. Was there anything else that you wanted to go over, Melissa?
I don't think so. I think that's really covered it. Maybe just not sure if I mentioned that I also use the framework in written documentation as well. And I actually provide a copy of the article to some people as well. I certainly provide references. And again, I think this is just a really nice way to communicate this within the wider healthcare team about what we're doing and why. And also, as I said, for everyone to be aware of the variables and potentially things that they can contribute to that as well.
Thank you very much for coming in today to chat, Melissa. Thanks for tuning in to the Dysphagia Research Bites podcast. If you'd like more dysphagia education, then head over to Instagram at Dysphagia Community. Or if you want to attend a live in-person dysphagia workshop that's evidence-based, practical, and fun, then check out Beyond the Bedside, Managing Dysphagia in the Community at dysphagiabites.com. Keep those hyoids high, everyone. Bites. I stuffed up my chopsticks.
One thing that you had to